Good morning, Pam.
Good
How are
morning,
you
my
today?
friend. Good to see you again.
Good to see you. Yes, we need to do this more often,
We're trying.
just to have a good discourse. But as I look at all social media and I see all these people asking all these questions, and it's very frustrating because of the confusion. The confusion of I need to see an oral surgeon, and the biggest confusion to me, when people say, "Well, it's going to be a month before I could get an MRI." Okay, so an MRI, a cone beam, Panorex, those are the different types of equipment that we use to see what the joint is doing.
Right.
And I want to ask you questions about that because I know you've had a cone beam and which needs to be described and how it's different than an MRI and the importance of imaging and how important and is it the thing to diagnose TMJ? And my answer is no, it's not. But I'm going to let you elaborate on that. And let's open up. So tell it like it is, girl.
So you don't want me to hold back.
Almost the whole thing, the whole enchilada.
So 100%. Imaging is not the end all be all of how to diagnose any kind of TMD issue, any kind of temporomandibular disorder issue. But we do need to understand anatomy. So there is a place for it, correct? So let's start with the different ones that you just brought up. A panorax to our listener is a two-dimensional image that goes around the head. I mean,
So
any
what do you mean? What do you mean by two-dimensional? Let's break this thing down. I'm going to be
like
hard on you.
that's okay. Don't stress me out, man. It's Friday, but I'll do my best. Two-dimensional meaning like it's a photo, it's a flat image, like it's a printed image on a screen. You cannot roll around it. You can't see it in all different views and truly understand the anatomy in 3 dimension. Okay. So,
Right.
so because it's two-dimensional, there's a lot of distortion. In my opinion, it should not be used at all to help diagnose a TMD dysfunction issue, right? It should
Correct.
be, that was once upon a time when we didn't
And
have.
that's all you have. That's
Exactly.
that's
A
all
lot
you
of
have.
oral surgeons still use that machine to look for wisdom teeth, to see where they are. And honestly, our listeners, the reason why people use Panorex still is because it's cheap. Flat out.
Cheaper.
It's cheaper, not to the patient, but the equipment itself is a lot less expensive. We're talking $20,000 to $40,000 versus $180,000 piece of equipment. So it's
Right.
one of those things, you're getting what you pay for. The information you get is just what's extracted from whatever machine you have, right? So that's
So since you brought that up, because I think this is extremely important, you have a machine, and
Mhm.
anybody that has a machine that shows the skull and it shows 3D, which you're going to explain, you're talking about 150 to 200 grand
Correct,
for that one piece of equipment.
correct.
That when patients walk in, I mean, they think it's really something that what it can do is just beyond belief. But I don't think anybody thinks of the cost
Right.
that it has to the person who's doing it, which is very important because it has to do with what the cost of treatment is.
100%. And, not to go down that road again, that doesn't include software updates that you pay for and subscriptions, and then also having the training on understanding how to interpret that information, not just from me, but also my team that works with me. They need to have an understanding of what we're looking at so they can help patients go through it too when they have questions, right? So all of
And
that
training,
training, that's all money and time.
right?
So a CBCT, since you bring that up, to me, that if I'm going to use imaging, that is one of the most accurate ways of looking at it because it shows things in 3 dimensions.
So what does CBCT mean?
It's what, oh geez, what does it mean again? It's
Cone beam,
computerized tomography.
yes.
Yes.
So big a word, we don't even think about it. We just say, oh, it's a cone beam. Okay,
CBCT.
there
Plus,
you
when you
go.
say the big words to patients too, their eyes glaze over. My team does too, and I just did.
But it's really a CAT scan. If you want to break it down to something that's easy, it's
It
big words, but it's a CAT scan and it shows hard tissue. So explain my statement on that, showing the
So
hard tissue.
it is a CAT scan, but this is something you stand in. It's not a tube that you lay into in any way, shape, or form. And it takes maybe 2 minutes to get all the information. The one that I have takes a scan of the top of the head to the middle of the neck, which is C3, C4 area, your cervical vertebrae, your spine. So the one that I have not only shows hard tissue, meaning bone and teeth, it does show soft tissue matter too. So I can see tongue, I can see inside the nose, like looking at the turbinates, looking at the septum, looking at adenoids, which is, you know, the stuff in the back of the nose, like tonsils. I can also see tonsils. So I have the opportunity of looking at things from a three-dimensional inside out turn any way I want, and right there real time with the patient on an extremely low dose of radiation. I'm talking less than 30 minutes being in the sun. So I feel good about that. I do it on my own children. I do it on all our patients, because without having the concept of the anatomy, what's the person's makeup like? I don't know how to treat them. Not the joint, not the nose, not the mouth. So I do believe where imaging is important, that's the one scenario I always use it for. Now, you also brought up MRIs to me before. And guys, I know I'm going to get burnt on this one, but an MRI is a complete waste of money and time when it comes to TMJ diagnosis. Okay.
I'm
All
going
it,
to agree with you.
right?
I agree.
So our colleagues, oral surgeons, I mean, I think it's a litigious reason, you know, like they're trying to protect themselves if they get sued, is what I mean, because attorneys don't know anything about anatomy really and function and physiology. So they'll say, did you take an MRI to say if why is that joint clicking and popping? Don't you need to know, doctor, where that disc is? And only the MRI will tell you, because an MRI shows predominantly soft tissue. It tells any doctor where the TMJ disc is located. Is it in front of the ball? Is it to the side of the ball? Is it on the inside of the ball? You don't need an MRI to say that there's a disc dislocation. You
Right.
can just simply feel it, like we've talked about in our previous podcast. If you feel it clicking, or you hear a popping or crackling in the ears, sometimes if, again, when you open and close the mouth, if the jaw doesn't open and close straight and it has to wiggle or deviate, that's a sign that the disc is not where it needs to be. So why am I going to put a patient through the expense and the terror of an
Exactly.
MRI? I would
Exactly.
do it, and I still don't do it. And God forbid, if anybody wants to go after me, I'm going to say I don't need it, because my clinical examination shows that. My CBCT tells me what the joint position is. So I have an idea where the disc is. I just need to know if I can capture it so the joint can start functioning correctly.
And what if you can't capture it?
What do you mean by that, Mac?
If you can't recapture a disc that's been displaced for years and years and years, which is sometimes impossible, you have to create a harmonious bite with the type of dentistry that you do, so that, like I've said over and over again, if you remove the offending agent, which is a bad bite, which is a compressed condyle, if you remove all that with an appliance that allows the jaw to be in a harmonious place, then that's going to allow that area to heal, no matter the position of the disc,
Mhm.
when you have a patient that's that serious.
Correct.
Okay. For one more thing is that everybody looks at, okay, where is the disc? Is it lateral? Is it this? Is it that? Is it this? My question is, why is it displaced?
Correct.
The why is the most important thing of all, not where it is, but why is it there?
Correct. Correct.
So that's what's so important. So we have been spending all of these previous podcasts, and the main thing, one of the main things we've been talking about, which I want to really keep getting over and over and over, is the deficient maxilla.
Mhm.
So here's a question I don't have an answer to, because I don't have a cone beam. Can a cone beam diagnose a deficient maxilla?
Yes.
Okay. And a cone beam can tell you where the position of the joint is, whether it's too far back or whether it's misplaced, correct? Your cone
Correct.
beam can.
Yes,
That helps guide you into what kind of treatment it does.
correct.
But is that a diagnosis?
No, it's a guide, like you said.
It's a guide.
It's a guide.
Okay. And one of my other pet peeves of reading these social media posts is that,
Hang
oh, I
on
went to,
a second. I don't want to lose this thought. All equipment that we use, they are a guide. It is up to the doctor to interpret all this information and the intake from the patient, the clinical exam to create the diagnosis.
that's correct. 100% correct.
So I'm
And
sorry.
no, you're right on target. You know, so the other pet peeve is they think they need to go to oral surgeon, but the oral surgeon hasn't been trained in what we're talking about.
Right.
The other thing is the oral surgeon says, well, you have arthritis in the joint. When you compress a joint, and I don't care where it is, you're going to have remodeling and reshaping of that condyle or of that joint that appears to be arthritis. So if you bring that joint forward, like I was just talking about, and allow it to have harmony and not being compressed, what does that joint do? And does your imaging show you before and after on
Yes.
a joint that's been messed up, and then you put it in a harmonious position, and all of a sudden, wow, that looks so much better. What's
Yeah.
your experience in that?
When we create our orthotics, the appliances that you're talking about, we immediately take another CBCT to validate the position. I want to make
Right.
sure I got that joint in a position that it has the right amount of space to recapture a disc. Okay, so to go back to some anatomy to our listeners, remember every joint is a ball and a socket. And the TM joint is show your book, Mac. Yes, for those watching on YouTube, every joint is a ball and a socket. And every joint needs some kind of lubrication to function because we can't have bone on bone. Our body will not allow that. So there's always synovial fluid, and the TMJ has a disc. And a disc by definition is round. And this disc happens to look like a lightsaber. It's thin in the middle. So it sits on the perfectly round ball that's attached to our lower jaw, our mandible, and it sits right inside the skull where there's like a little cup that fits that ball in it, right? Now, if that joint is pushed up and back towards the ear, the disc is going to be displaced in front, to the side, to the inside. It's not in the right place. So when people open and close, we hear that click. We hear the pop. So on the CBCT, what I'm looking for is, I'm looking at the joint position. Is that ball too far back? Is the right side sticking out this way and the left side in? You know, I'm trying to see where that space is so that I can create an orthotic that gives you that nice concentric or even space around the ball so the disc can pop back on and now the joint can glide when you talk or when you chew. So that's how I use CBCT imaging to like verify my joint position. Now situations happen sometime where, like you said, it's just a ruined joint. It's been bent and compressed and remodeled. Arthritis by definition is an inflammation in the bone, right? So
Correct.
sometimes it's tender to the touch, not always, okay? And then also the bone starts to remodel, form follows function. So if the joint's been up and compressed, like Mac is saying, the ball doesn't look like a ball anymore. On the CBCT imaging, we see that areas are flat. And sometimes the ball has got a straight neck to it. If you could put your book up again, Mac, it's got a straight neck to it. If it's been up and back for such a long time, it starts to bend. And then even the ball will start to look, it'll beak like a bird. So CBCT, not only do I use to create the right position for the jaw, like a balanced physiologic position for the joint to work right, but it also helps me give realistic expectations to the patient. If that joint looks terrible, Well, I know that disc is probably damaged too. It's made of cartilage. So I can get you to start functioning right, but will you never hear a noise again? Not if that joint looks terrible. Will you be out of pain? Absolutely. Will you function and have a great quality of life? For sure. You know, the younger the joint, the less damage the joint, the better the outcome and longevity of that outcome will be, right? But if it's
Right.
been pretty mangled, we're still going to get you feeling so much better. And you'll know that in that first phase of the orthotic treatment. But it really helps me to determine, did I get the bite position right? And then also the predictability and the outcome, set up my patients' expectations correctly, you know, because they get to feeling so awesome and so great. They start like, wondering about the little things. Like now they worry about cosmetics or, you know, 4 months ago, I heard it click. I'm like, it's okay. You're never going to go back to ground zero. Remember that joint had changed. And that's why
Yes. Yeah.
flip, you know?
And it's just amazing, the human body, and I've been observing for a long, long time, how the body will heal if you take away that offending agent. And I don't care if it's bacteria, I don't care whether it's a bad lifestyle habit, I don't care what it is. If you take away that offending agent, you're going to get healing. That's just the way, the miraculous of the human body. Okay, so let me kind of go back over this again. You have a cone beam, and
Mhm,
the cone beam will look at hard tissue.
mhm,
And the joint is made up of hard tissue, of the skull, of how the condyle fits into the socket. And then you have a disc, which you cannot see, not really on the cone beam, but we've just now established that it's not that important to see it. What is important to see is the space
mhm,
and to see whether it's being compressed or not. So if you see a patient on a new patient exam and you go through all of the things that you go through, which I'm going to ask you those steps, and you come to the stage of taking the cone beam, and it's all digital, pops right up, and there you see that there's no space. It's being pushed up against the bone somewhere within that fossa or within that socket. Then you're able to use instrumentations, you're able to use your experience, you're able to use your knowledge in saying this needs to come forward. In fact, that left needs to come a little bit more over here because I picked up on the cone beam that the left is being more compressed than the right, et cetera, et cetera, et cetera. You can take a little gun that has paste in it that sets up, and you can squirt it on the teeth on the position what you think your clinical experience tells you. I think this is it. Plus, using EMGs where the muscles are relaxed, you got a pretty good idea that that's where the harmonious spot is. You use that, and then you go and take another cone beam to verify that you have changed that joint position to where it's more neutral and in a more harmonious position. Am I on target here?
100%.
Okay, so when you break it all down, dentistry, I mean, this is not that difficult to understand. It's difficult for dentists to accept, but it's not difficult to understand.
Maybe
You
to
get,
us because we studied it for like ever. Try, you know, when you talk to
but
an
we concentrated on this and we concentrated on the anatomy. We didn't concentrate on why is it screwed up. This is what the thing is. Why it's screwed up is because the upper and lower jaw don't are not in harmony. And the jaw has to go back. When the jaw goes back, the condyle goes back. When the condyle goes back, it compresses itself into the socket. It's
right.
not rocket science.
Okay, you're getting
Now,
super clinical. We got to break it down for our listeners. We're throwing a lot of big words out there. I know
I
some
did.
of them are doctors, but we're talking to people, patients.
Okay. So again, if you use the C with your left hand and you make a fist with your right hand, there has to be space around the C. And I hope everybody goes to the YouTube video, which we'll post in the notes on this podcast. But this is the way the condyle needs to be, not here and not here and not here and not even over here. So which can happen also.
Mhm.
But learning how to make that appliance that guides the joint into that harmonious place, which separates the men from the boys and the girls from the women. So it is the key that the dentists have such a hard time wrapping their heads around. And that's why you, as a pain sufferer, having such a hard time finding somebody that can help you.
With that being said, let's explain this to listeners. The reason why that if you have quote TMJ, your medical doctor, because Max said this before, most people seek care with the medical doctor first because it's in their
Right.
head. They don't think it's because of the jaw and the teeth. So the medical doctor sends you to the oral surgeon because that's what they know. They're going to need to do something to the joint, and a surgeon does things to the joint. Oral surgeons don't have the type of training Mac and I do. The training they have, and when they're really helpful, is that if there is like somebody who through birth or for unknown reasons, that ball on the mandible, it starts to disintegrate, the resorption, call that. And then that's when people need joint replacement. That's the only time people need joint replacement. Or if you suffer a massive accident, it needs to be, and it breaks, it needs to be put together and fused. So that's great for oral surgeons. Sometimes oral surgeons will also put injections like PRP in there. Sometimes they'll inject fluid to help the joint lubricate and function better, because we talked about that. We need lubrication. Those things are temporary fix that can be helpful. But like Matt keeps saying, let's talk about what caused the problem. And it's the position of the lower jaw that caused the problem, caused the compression in the joint. And the way that, in my opinion, the way that I have success treating patients is that, one, I look at the intake from the patient. First, we got to know their history, right? You need to understand what their pain is, what they're chasing, what are we trying to fix? What are we trying to achieve here? Because they can have messed up anatomy, but if they're wanting to be treated for their eyes, well, I need to make sure that their eyes are healthy and they've seen the ophthalmologist before I think it's a muscle spasm because of a joint posturing issue. So we got to check the boxes. But anyway, it's the intake from the patient first, looking at their anatomy using 3D technology, the CBCT, understanding where the muscles are comfortable with electromyography, EMG, and then looking at how they are functioning when they talk and how they chew. And then lastly, their posture. Those things all come together. And with that background and knowledge and information, that is where I make the devices to fit their bite in a balanced physiologic position. To me, it's that simple.
Yeah, it really is.
Easy, right?
And then if you've been doing this long enough, you just kind of look at somebody and say, oh, yeah, I know. So you remember the massage therapist that I had in my office, Chris, the
Yes,
Olympic
yes.
level.
Oh, he's fantastic.
I
Yes.
mean, he's just a genius, and he did massages in my practice, and he would get behind a patient and watch them walk, and he knew exactly what muscles were not working correctly, and so experience is just so important.
Mhm.
And what we're trying to do with these podcasts is for you sufferers to have a really good idea of what you're walking into, and if you're not getting what Pam is explaining when you're getting the first exam, and because to do the exam, you get the diagnosis and you get the treatment plan. If you're not getting that very comprehensive uh, experience, you're probably not in the right place. Now, it just again, it depends on how difficult your TMD problem is. So, I think that this is I would encourage Pam. You have patients come from all over, right?
We do. We do have patients that come from all over different states. We can treat phase one, and phase one is getting them out of pain, getting the quality of life back to normal, giving them an understanding of why they got here and how this is going to help. And then once they're out of that emergency point in their life and they can breathe and function, we talk about how to go into phase two. And yeah, we have people come all over, but it's just we want to make sure they understand, is this a TMD issue and why? And that's how we do it. So,
And that's why I wrote this little pamphlet. It's not
so
really a book. It's just a little pamphlet, but what it has in it is pictures of the joints and all the things that we've been talking about today. And
that's a
it's the
great
life-robbing pain of TMD. It's on Amazon all over the world.
a life
Yeah,
TMD.
I
That's
encourage everybody to have a look at
great.
that. And then write us questions, ask us questions.
Please do. And, we're going to get into that in our next podcast. But I hope that this was really helpful and we broke it down well. Fingers crossed. Listeners, let us know what you think.
Yes, and sign up to our YouTube and to our podcast.
That's right. We have to keep reminding people to do that. Please do. All
Yeah,
right. Until
please,
next time.
please. Next time.
Bye-bye.
Later.